Before we start this debate, let's get some things very straight. We all agree upon the need to do a meniscal repair. So before the audience starts to confuse me for a primitive Cro-Magnon man, in this case with an arthroscope in his hand, let us be clear that acute meniscal tears which are worthy of repair must be repaired. The debate here is a repair of a delayed presentation of a bucket handle tear of the medial meniscus. And in order to understand how late is delayed, we really have very limited guidance in literature on what is a delayed meniscus tear. Is it 6 months according to this particular paper? Or is it 3 months? This particular paper, which is very widely quoted, says a delayed repair is 3 months. Some papers have even reduced the time to 6 weeks, which we obviously know is not a delayed presentation of a meniscal tear. Or is it as low as 4 weeks? So we really need to get an understanding of how late is delayed. And when this topic was given to me, this is something which I do in my own practice. I don't repair bucket handle menisci beyond 3 months. For me, a time of 3 months is somehow a cutoff time. Of course, there are exceptions. If you have a young patient, I would probably go ahead and do it more than 3 months as well. But 3 months is kind of an upper ceiling for me, and generally I follow the advice given in this particular paper. And I'll be showing the results that this paper has posted. And the reason why we, or at least I, don't do a delayed repair of the bucket handle meniscus tear is that the results are not that great. I mean, this is a very recent paper in the December 2022 issue of American Journal of Sports Medicine. Even in 13 to 25-year-olds, the surgeons reported a 7% reduced incidence of repair after each month's delay in an ACL reconstruction. So this obviously is a repair of a bucket handle meniscal tear in association with an ACL tear. Now let's understand how we define meniscal healing. So despite all the technological advances, the criteria for defining meniscus healing clinically and radiologically are actually in the late 20th century. So Barrett's criteria of absence of swelling, presence or absence of clicking or locking, or joint line tenderness, and a positive McMurray are used as clinical criteria of healing for a meniscus. The radiological criteria date back to 1986, Henning et al. No intrameniscal fluid is a fully healed meniscus, Henning 1, less than 50% and more than 50% are Henning 2 and Henning 3 respectively. And these are the criteria that most papers, the recent ones also used to quote the repair of the meniscus or the healing of the meniscus. Now there are quite spectacular results after after the repair of a bucket handle tear. This particular paper reports a more than 80% healing. But then these are tears which are operated within 2 weeks. So these are acute tears. Now this paper, which said just a 3-month delay, now they have reported only 27% Henning 1, that is fully healed tears, when they have repaired the meniscus tear at the end of time span of 3 months. So this is a figure which is worth looking at. It's not a very happy scenario. Of course, if you combine Henning 1 and Henning 2, the percentage rises to I think 56 or 58%, but still half of your menisci are not going to heal. So this was a very interesting editorial commentary, and in fact, I wanted to ask this as a question to Dr. Anil Ranawat on what side of the fence he's on. This particular editorial commentary was on the repair of a root tear of the lateral meniscus, and Dr. Shelbourne gave a very nice editorial review, and this was followed by an almost cricket team rebuttal from Dr. Rob Leprard and several other people. But in this particular review, he clearly mentions that we continue to repair many degenerative bucket handle medial meniscal tears with the knowledge that some patients may require subsequent surgery. So this is really something which must be borne in mind, repair of a delayed presentation of a bucket handle of the medial meniscus, particularly one which doesn't look very good, rounded off edges. Almost all delayed presentations are the ones in which we actually force ourselves into doing a repair by freshening the margins very aggressively and doing very advanced repair techniques. Now, OOPS is an abbreviation of out-of-pocket spending. And this is something which must be kept in mind when working in a healthcare scenario like India. So there are cultural differences in practice scenarios between India and what you see in America. Here the failure of a repair is not seen as a failure of biology, it's seen as a failure of a surgeon. And if one looks at the recent Oxfam report, which just came 3-4 days ago, there's a huge disparity in income. It's worthwhile noting that this particular report noted that a lot of Indians are pushed into poverty just by healthcare spendings. So we all work and treat ordinary people, and whenever we have a patient with a delayed presentation, the cost of a meniscal repair in terms of US dollars, just the cost of implant is around $1,000. Now this, when the outcomes are not that certain, is something that I would factor heavily when I am doing a repair or a surgery upon a bucket handle meniscal tear. My preference probably is to be a bit conservative, to excise a delayed presentation of bucket handle, because I feel that a delayed repair perhaps helps the orthopedic industry more than the orthopedic patient. Thank you very much.
Great talk. Raju, please join us here on the panel, and now let us hear what Anil has to say and why does he want to repair the delayed presentation of the bucket. You made a great argument, you showed some great papers on why we shouldn't do it, but let's see the counter side. Anil.
Well, first, I always lose my debate against Raju because he's got a cool mustache. You can't beat him with a mustache like that. So I'm just going to say I lost. No. This is I think he brought up a lot of the appropriate issues, and I don't disagree with most things that Raju said, because cost and 3 months, if that's your criteria, that's a pretty big number. Now the reality is, in the U.S. market, we don't see a lot of delayed 3 month out bucket handle meniscus repair tears, and in that scenario we would actually most likely excise it, and it's very common to see that in India, so I understand that. It's also fascinating. My cousin who's an English surgeon, when he was training in the NHS, he's my age, so around say 2001 to 2006, he never did one meniscus repair in the NHS because everything was delayed presentation, which is, it's a fascinating thing. So healthcare economics, your healthcare situation is really important. But just because he didn't do it doesn't mean it's right either. And what's right for the knee is only we're going to know 30, 40 years down the road. And that really comes with the power of registries. When we have registries and we can follow a knee and we know scientifically which knees need their meniscus and which knees don't, it's really important. The other thing I always want to think about meniscal loss, to me, is the acuity of the loss. Taking out a bucket handle acutely, that knee, it's like you have your wife or your girlfriend, you dump her that day. It's very dramatic. And that knee then will get overload immediately. If that knee has seen meniscal loss or that bucket for a long period of time, 3 months, it's gradually scleroticized is the term I use. That bone got harder and it can accommodate meniscal loss. So understanding the quality of the bone, the patient, the alignment, this is all how you can prevent, I think, meniscal varus or sponk or overload. And how I manipulate compartmental overload based on all those factors are all in my treatment algorithm. So let's go. Obviously, we know about the anatomy. We want to restore the hoop stresses. This is the classic paper from HSS from Steve Varnarski. And we understand that, how the importance of meniscal function of a stabilizer of the knee from both a contact mechanics, but also from a stability point of view. And, here's the thing. We know when you repair meniscus, and if it heals, it restores physiological function. It will prevent OA. The outcomes are pretty good, and the healing rates are pretty good for, but, they're not perfect. It's about 75 to 80%. We also know that if you have a torn ACL and a bucket handle, that this is really a setup for a knee that will fail. So if you look at the original Fairbanks article, the knees that do worse, if you ever have an ACL deficient knee and do a meniscectomy, that is a no-no. And that's something I never, ever do. I tell a patient, I am not going to operate on you unless at least I can fix your ACL, because that knee can't take that double hit. So we know the medial meniscus with a lot of meniscal loss and the ACL are brothers. They need to work together. So that scenario, if you are going to remove the meniscus, you have to at least fix the ACL. So, the other issue is that what does it do? It also prevents OA. This is a pair of 66 patients, mean follow-up for 114 months, and we know that failed repairs have higher arthritis. So if we're just looking at cost at times zero, it's not saying the whole story. This whole story is 10, 20, 30 years down the road, and that's the power of registries to understand that information. We also know, if we do it in conjunction with an ACL, and if you look at all the systemic reviews, about 17 studies, that, we have a pretty good failure rate, and it's pretty low. And actually, the medial side had a little bit of that are isolated have a higher risk of failure, which we all know that. Sometimes that's like a debatable thing, isolated medial versus isolated lateral. But I do think for larger tears, the medial side, usually because I think they're more invarus, are more likely to fail. And this is from Saffinini. We also know that there's good repairs. This is 50 patients in terms of their outcomes once we do kind of fix it. So fixation does matter. I would also argue the quality of your repair. Using all inside implants are very costly. Is one thing, but using all suture to me is a cost-effective. Those needles are much cheaper. You get better fixation. You can put more implants in, and you have smaller holes in the meniscus. So I still like inside-out sutures for my bucket handles. I still do it, and it's a smaller, more cost-effective agent. So if you're going to think of just cost, then you got to understand there's a ways to get around cost. And, let's talk about ultimately the timing of surgery. And this is a paper, 88 ACLs with bucket handle meniscus tears. And they had an 82% survival, and they didn't really see much of a difference from 3 weeks, 3 to 10 weeks, and greater than 10 weeks. Obviously, the greater than 10 weeks is really, if you want to focus on that 3 months, but this is probably the best data to show that if you're doing an ACL, you can attack a chronic bucket meniscus tear. And obviously, we have good healing rates on second look arthroscopy. And again, if you look at most of these constructs, these are not using arthroscopic all-inside implants. These are using inside-out traditional techniques. So, when do I repair it? A young patient, concomitant ACL, red or red-white, good tissue quality. I will routinely do a partial meniscectomy and a meniscus repair. And obviously, you want to do this on less arthritic knees. The biggest thing you have to understand with these chronic ones, can you reduce the meniscus? And if you don't, and if you can't, well then, do you have to maybe do a partial meniscectomy? Do you have to manipulate the MCL to do that, to reduce the knee? But if it's a young patient, I have no problem in reducing the MCL. And as I said before, you want to really, get a lot of fixation. So this is, obviously a grade 3 MCL and more of a multi-ligament knee, but I use inside-out sutures routinely. You can use all inside implants, certainly in the back. In the front, I will go outside in, but fixation matters, number of sutures matters, and I think we're getting a little lazy in meniscal suturing and just using 1 or 2 all inside. We call it horizontal, but it's really more vertical, is not the right way to do it. So, the data is pretty clear that delayed presentation from greater than 10 weeks to under 10 weeks hasn't really been shown to be that much of a difference. I think the correct technique is really the best thing. Partial meniscectomy is always an option, but you have to know which patient you're doing it on and follow them accordingly. Thank you very much.
Thanks, Anil. Great debate. I think both have merits and demerits, but let me ask Andreas, even though he's from HSS, let's see, he's the judge. So who wins? Does Raju win from Delhi, where you were?
One question. What was the cricket team line? I didn't understand that. Can you explain that to me? You said, Raju's like,
rebuttal.
Yeah, the rebuttal was like it was like a cricket team attack. I didn't get
what
the
he meant was 11 people were against.
Yeah, so
okay.
that editorial commentary was authored by Dr. Shelburne. Mm-hmm. The rebuttal to that commentary came from Dr. Rob Leprad, Lars Engebretsen. There were nearly
11 people.
11 people, gotcha. Well, if you know anything about Don Shelburne, he always walks to his own drum. He's a little out there, but he's a very smart man. But Andreas, who won the debate?
Yeah.
Well, I can't argue with the whole beard comparison. I don't know if you forgot to shave this morning or... but so I would say overall, pragmatism won out. So what I mean by that is Anil provided a beautiful overview of the scientific merits of why do you repair a meniscus, and Raju brought this right into reality because sometimes, even though we would love to repair it, sometimes we can't. And I personally don't look specifically at a time I want to see if I can reduce the meniscus, and if I can reduce the meniscus, I would repair it. If I can't reduce it because it has healed into the notch and has sort of shriveled up, then I don't repair it. The time is helpful to tell the patient how likely this is. If someone is 6 months out, I tell them, we'll take it out and you have an easy post-op.
Exactly, I agree with Andreas. All I would like to say is that whenever you have an opportunity to present it, I think the duration doesn't matter. As long as the tissue looks good, it is not, looking completely delaminated, I would make an attempt to repair it, even if it is 3 months or maybe 6 months. So that's what my take is, because for the various nice articles which Anil showed us, what is the function of the meniscus, the biomechanics. If you excise it, and let's say even if it doesn't heal, or it will act at least as a filler for some time, 6 months, 1 year, before it completely fails, and it would definitely delay the arthritic changes. That's how I would look at it. So, let's have a quick comments from Raju and then Anil before we end this session. And what is your message to the house? We have 200 people in the hall now. So what would you say to them? Forget the debate. Now you're friends with Anil, okay? No more enemies.
So I'd echo the same feelings. You need to know what delayed is, how delayed is delayed. And I think there was a difference of perspective. So in the Indian scenario, we get patients at 3 months and 6 months with bucket handle tears. And they ask, Doc, can you repair my meniscus? We need to give them a realistic answer. Delay in an American setting might mean 3 weeks and 6 weeks. But here we sometimes get patients with an ACL tear coming to you after a year, 2 years with meniscal tears. Then the confusion is, was the tear pre-existing? Is it a fresh tear? So you need to give a balanced answer to your patient. And in most of our settings, healthcare cost will come. Of course, we have insured patients, but we are seeing that insurance is also frowning heavily upon the cost of implants. To repair a bucket handle tear of the meniscus is a very sizable proposition. So I would suggest that you keep that in mind and give a balanced answer to your patient.
Great. Your comments, Anil.
Yeah, no, I think Raju really presented a very well-balanced and appropriate argument, and Andreas kind of nailed it, is that it's really, everything in orthopedics is not about age or time. It's always about functional age and functional tissue. And that's, we don't say, oh, you're over 60, you can't get meniscal allograft. We care about how your cartilage looks like. Everything is always relative, and you have to keep an open mind on a lot of variables. So,
Yep,
save the meniscus.